Welcome to my YouTube channel, Elite Health Tips. What if the biggest risk in modern medicine is not a failed surgery, but a successful surgery that quietly changes a person's life forever? Most people walk into a hospital believing that if the operation goes well, everything else will naturally fall into place. That is exactly what Barbara believed at 72 years old. She was sharp, independent, active, and still living life completely on her own terms. One Tuesday afternoon, she entered the hospital for what doctors described as a routine knee replacement. Her daughter later explained that the surgeon made the entire procedure sound simple. 6 weeks of recovery, a little physical therapy, and life would return to normal. But normal never came back. The surgery itself was technically perfect. The surgeon did exactly what he was trained to do. Yet only a few days later, Barbara developed a dangerous pulmonary embolism. Then came pneumonia during recovery. After that, her kidneys began struggling under the pressure of medication after medication being used to control every new complication. 19 days after surgery, the woman who once walked her dog every morning was suddenly trapped inside a hospital room, fighting problems she never expected. 4 months later, she finally returned home, but not to the life she had before. She came home to a recliner. She never walked her dog again. And that is the reality almost nobody explains clearly enough before surgery. Sometimes the operation succeeds while the patient's quality of life does not. That gap between a successful procedure and a genuinely good outcome becomes critically important after the age of 50. This conversation is not about fear. It is not about telling people to avoid surgery. Modern medicine has saved millions of lives, restored mobility, relieved pain, and given people decades they otherwise would not have had. But there are certain surgeries where the risks are often minimized, the alternatives are rarely discussed honestly enough, and patients are pushed toward major procedures without understanding the full picture. Doctors call it physiological reserve. When you are younger, your body has extra capacity hidden in the background. Your heart, kidneys, lungs, liver, and immune system are operating far below their maximum limits. So when surgery places the body under stress, the system can compensate. It can recover quickly. But as people age, that reserve slowly decreases. It does not mean the body is weak. It means there is less margin for error. By the time many adults reach their mid-70s, nearly 1 out of every 3 has some degree of frailty, even if they still appear functional from the outside. That matters because surgery is one of the most stressful events the human body can experience. Anesthesia suppresses the immune system. Long hours in bed increase the risk of dangerous blood clots. Post-surgical inflammation can strain the kidneys. Pain medications can affect memory and thinking, especially in older adults. One of the most overlooked complications is something called post-operative cognitive dysfunction. After major surgery, many older patients experience confusion, memory problems, difficulty concentrating, or personality changes that can last for weeks or even months. Some families panic because they believe their loved one suddenly developed permanent dementia. In some cases, the brain slowly recovers. In others, it never fully does. Studies published in leading medical journals found that this condition affects a significant percentage of adults over 65 after major operations. Yet many families are never warned ahead of time. That is why age changes the surgical conversation. Older adults absolutely can have successful surgeries. Thousands do every single day. But the balance between risk and benefit shifts, and that shift demands honesty, preparation, and better questions. The first surgery on this list surprises many women because it has become so normalized that few patients stop to ask whether it is truly necessary. Hysterectomy, the removal of the uterus, remains one of the most common major surgeries performed in the United States. Hundreds of thousands of women undergo the procedure every year. Yet research has suggested that a large percentage of these surgeries may not actually be medically necessary, especially when performed for non-cancerous conditions. Women over 50 are often advised to have hysterectomies because of fibroids, chronic pelvic pain, abnormal bleeding, or uterine prolapse. The problem is not that these conditions are imaginary. The problem is that many patients are not fully informed about the non-surgical options that may effectively manage those conditions with far lower risk. Hormonal therapies can sometimes control symptoms. Procedures like uterine fibroid embolization can shrink fibroids without removing the uterus. Endometrial ablation may reduce bleeding significantly. Pelvic floor physical therapy can improve prolapse symptoms in some women. Yet in many clinics, the quickest and most familiar recommendation becomes surgery. What often gets overlooked are the long-term consequences, especially when the ovaries are removed along with the uterus. Research from long-term studies has linked ovary removal before age 55 with increased risks of heart disease, stroke, osteoporosis, and sexual dysfunction. These are not minor lifestyle changes. They can permanently alter health and quality of life. So if a doctor ever tells you that hysterectomy is your best option for a non-cancerous condition, the most important response may be a simple question: what are all of my non-surgical alternatives, and why are they not being tried first? That single question could completely change the direction of your care. The second surgery almost never becomes part of everyday conversation, yet it affects thousands of older adults every year. It is called carotid endarterectomy, a procedure designed to remove plaque buildup from the carotid arteries in the neck. These arteries supply blood directly to the brain, so the goal of the surgery is understandable: reduce the risk of stroke. For certain patients, especially those who have already suffered a stroke or a transient ischemic attack, the operation can absolutely be life-saving. When arteries are severely narrowed and symptoms are already present, surgery may provide a real benefit. The concern begins when surgery is recommended to patients who have no symptoms at all. Modern imaging technology has become incredibly advanced. Doctors can now detect plaque buildup long before it causes obvious problems. That sounds positive on the surface, but it has created a new issue. Many people are now being told they need surgery based entirely on scan results, even though they have never experienced a stroke warning sign. Large clinical studies found that for many asymptomatic patients, aggressive medical management with blood pressure control, cholesterol medications, exercise, and lifestyle changes performed nearly as well as surgery in preventing future strokes. Yet surgery still carries immediate risks. During the procedure itself, patients face possibilities such as stroke, heart attack, bleeding, or nerve injury. In other words, the very complication the surgery aims to prevent can sometimes be triggered by the surgery itself. Even a small surgical stroke risk becomes important when the patient currently feels completely healthy. Imagine being asked to accept a serious, immediate danger today in order to reduce a possible future danger that might already be manageable through medication and lifestyle changes. That does not mean nobody should ever have this surgery. It means the decision should be individualized carefully. One of the most important questions a patient can ask is whether they are symptomatic or asymptomatic. That distinction changes everything. Patients should also ask how current research compares surgery versus medical management for someone with their specific health profile. A trustworthy surgeon does not become defensive when questioned. A trustworthy surgeon welcomes informed discussion because medicine should never rely on blind trust alone. The third surgery on this list shocks many men because it involves one of the most emotionally frightening words in medicine: cancer. Prostate cancer is one of the most common cancers diagnosed in men over 50. And once someone hears the word cancer, the instinct is immediate and understandable. Remove it, eliminate it, fight it as quickly as possible. But prostate cancer is unique because many cases grow extremely slowly. In fact, a large percentage of modern prostate cancer diagnoses involve what doctors classify as low-grade disease. Some oncologists even describe certain prostate cancers as conditions men are more likely to die with than die from. Long-term research, comparing surgery, radiation, and active surveillance, found something surprising. For many men with low-risk prostate cancer, survival outcomes were nearly identical, regardless of whether they underwent immediate surgery or simply monitored the disease carefully over time. Yet robotic prostatectomy, the surgical removal of the prostate using robotic systems, continues to be performed at extremely high rates. Part of the reason is psychological. Surgery feels decisive. It feels like action against fear. Hospitals have also invested enormous amounts of money into robotic surgical systems, and many patients are never presented with active surveillance as a truly acceptable alternative. What makes this decision especially important are the long-term side effects that can follow prostate surgery. Urinary incontinence can persist long after recovery. Erectile dysfunction remains one of the most common and devastating complications. For many men, these changes affect confidence, relationships, independence, and emotional health. These outcomes are not rare footnotes hidden in medical paperwork. They are life-changing realities that deserve honest discussion before surgery is scheduled. That is why every man diagnosed with prostate cancer should ask three direct questions. What is my Gleason score? What does active surveillance look like for someone with my exact risk level? And what are the long-term quality of life differences between surveillance, surgery, and radiation? Those questions force the conversation away from panic and back toward evidence. And sometimes, evidence tells a very different story than fear. Back pain is one of the most common reasons adults over 50 seek medical care. Nearly everyone eventually experiences stiffness, disc degeneration, or chronic discomfort in the spine. For many patients, the pain becomes so exhausting that surgery begins to feel like the only remaining option. Over the last 2 decades, one procedure in particular has exploded in popularity: multi-level spinal fusion. During this surgery, surgeons permanently join two or more vertebrae together using screws, rods, or hardware to eliminate movement between painful sections of the spine. For certain severe spinal conditions, fusion surgery can absolutely be appropriate. But for the most common type of age-related back pain, degenerative disc disease without major nerve damage, research has repeatedly shown that long-term outcomes are often no better than non-surgical treatment. That fact surprises many patients because surgery is usually presented as the final and strongest solution. But large studies comparing spinal fusion with aggressive physical rehabilitation found that many patients achieved similar pain relief and functional improvement without permanently altering their anatomy. The risks, however, are substantial. Older adults undergoing complex spinal fusion face high rates of complications including infections, blood clots, hardware failure, and adjacent segment disease. Adjacent segment disease occurs when the vertebrae above and below the fused area begin deteriorating faster because stress has been redistributed unnaturally. And unlike many other treatments, spinal fusion cannot simply be reversed. Once sections of the spine are fused together, the anatomy changes permanently. That is why non-surgical treatment deserves far more attention before anyone agrees to this operation. Structured physical therapy programs, targeted rehabilitation, nerve block procedures, epidural injections, weight reduction, and muscle strengthening can significantly improve function for many patients. One patient in his late 60s had already visited 2 spine surgeons who both recommended fusion surgery. He struggled with severe lumbar pain and believed surgery was inevitable. But instead of rushing him into the operating room, his medical team referred him to a rehabilitation specialist. Over the next 3 months, he completed an intensive physical therapy program combined with one carefully timed epidural injection. Slowly, his pain dropped from nearly unbearable levels to something manageable. Years later, he still had not required surgery. That story does not mean spinal fusion is always wrong. It means timing and preparation matter enormously. Before agreeing to spinal surgery, patients should ask whether comprehensive non-surgical management has truly been attempted first, not 1 or 2 therapy visits. A serious, structured, supervised effort. The fifth and most emotionally difficult category involves surgery in patients with advanced dementia. Families facing these situations are often exhausted, frightened, and forced into impossible decisions during medical crises. An elderly parent with dementia develops a fractured hip, an intestinal blockage, or a severe gallbladder infection. Suddenly, relatives are standing in a hospital hallway late at night, being asked whether surgeons should operate immediately. In many hospitals, the default response is intervention. Medicine is trained to act. Families fear feeling responsible if they decline surgery. And because many people never discussed end-of-life wishes beforehand, decisions happen under extreme pressure. But advanced dementia changes the entire recovery process. Patients may not understand where they are or why they are in pain. They may become terrified by unfamiliar environments. Rehabilitation after surgery often becomes impossible because the patient cannot follow instructions or communicate symptoms clearly. Studies examining high-risk surgery in dementia patients found that many spent their final months in institutions, confused, physically restrained, suffering repeated complications, and unable to regain meaningful quality of life. That does not mean families should feel guilty for choosing surgery. Every situation is deeply personal, but it does mean that comfort-focused care, palliative treatment, or hospice should be discussed honestly as medically appropriate options rather than viewed as surrender. One of the most compassionate things a family can do is have these conversations early, long before any emergency occurs. Discuss what quality of life means. Discuss what treatments would or would not be acceptable. Document those wishes clearly. Because when crisis arrives, families should not be forced to guess what their loved one would have wanted. There was a man named Victor who changed the way many people around him thought about surgery. He was 74 years old, a retired football coach with the kind of strong presence that filled every room he entered. But years of physical wear had destroyed his knees. Walking became painful. Stairs became exhausting. Two orthopedic surgeons had already told him the same thing. Both knees needed to be replaced. Victor and his wife believed surgery was already decided. They had started researching rehabilitation facilities and preparing for months of recovery. But during his evaluation, a different picture emerged. Victor's diabetes was dangerously uncontrolled. His blood sugar levels were far above what most surgical programs consider safe for elective joint replacement because uncontrolled diabetes dramatically increases infection risk and slows wound healing. He also had early kidney disease and signs of cardiovascular strain that required further evaluation. In other words, the issue was not his age. The issue was his physiological condition. Instead of rushing him into surgery, doctors focused first on improving the foundation of his health. He was referred to specialists who helped control his diabetes. He entered a medically supervised weight loss program. A physical therapist designed a rehabilitation plan specifically for his knee mechanics and movement patterns. Months later, the transformation was remarkable. His blood sugar improved dramatically. He lost weight. His knee pain decreased enough that he could once again walk his grandson to school several times a week. Only after his overall health improved did he choose to replace one knee instead of both simultaneously. This time, the surgery and recovery went smoothly. Victor's story reveals something critically important that many patients never hear. Preparation before surgery can matter just as much as the operation itself. That leads to 4 questions every adult over 50 should ask before agreeing to any major procedure. The first question is incredibly simple, but often ignored completely. What happens if I do not have this surgery? Patients are usually told what surgery can accomplish. Far fewer are told what watchful waiting, physical therapy, medication management, or less invasive alternatives might realistically achieve. Some conditions worsen rapidly without treatment. Others progress slowly enough that conservative management remains reasonable for years. A patient deserves to understand both paths, not just the surgical one. The second question involves frailty and surgical risk assessment. Older adults should ask whether a formal frailty evaluation has been performed. Medicine now has validated tools capable of estimating surgical risk based on strength, mobility, medical conditions, nutrition, cognition, and overall resilience. If a medical team has not evaluated these factors carefully, then they may not fully understand how an individual patient will tolerate surgery and recovery. The third question may be the most personal of all. What does realistic recovery look like for someone exactly like me? Not the average patient, not the brochure version, the real version. How will kidney disease affect recovery? How will diabetes influence wound healing? What happens if mobility is limited before surgery even begins? Will the patient have help at home? How much pain should realistically be expected during the first month? Everybody is different, and honest recovery discussions should reflect that reality. The fourth question is one many patients feel nervous asking, but it matters enormously. What is your personal complication rate for this procedure in older adults? Experienced surgeons track their outcomes carefully. Transparent physicians understand that informed patients have every right to ask about those numbers. A surgeon unwilling to discuss complication rates openly may not be giving the full picture. These questions are not confrontational, they are responsible. Patients should never feel guilty for wanting clarity before life-changing medical decisions. One of the biggest misconceptions about medicine is that refusing immediate surgery means refusing treatment entirely. In reality, modern healthcare has developed remarkable non-surgical options that barely existed a generation ago. Targeted biologic therapies now help many inflammatory joint conditions without requiring major operations. Focused ultrasound can treat certain neurological disorders without opening the skull. Catheter-based cardiac procedures allow doctors to repair heart problems through tiny incisions instead of open chest surgery. Even chronic pain treatment has evolved dramatically. Nerve block techniques, spinal cord stimulators, advanced rehabilitation programs, and minimally invasive procedures now provide relief for many patients who once would have faced major surgery automatically. And then there is one of the most undervalued concepts in medicine today: prehabilitation. Most people understand rehabilitation after surgery. Far fewer understand the power of preparing the body before surgery ever occurs. Research consistently shows that patients who improve strength, nutrition, blood sugar control, cardiovascular fitness, and mobility before elective procedures experience fewer complications, shorter hospital stays, and better recoveries. Some hospitals now require older adults to complete structured prehabilitation programs before certain operations because evidence has become so convincing. That shift reflects an important truth. The body wants to heal when given the right conditions. Too often, patients believe surgery alone determines success. But recovery depends on far more than technical skill inside the operating room. Nutrition matters, muscle strength matters, heart health matters, kidney function matters. Mental resilience matters, support systems matter. An operation performed on a poorly prepared body may technically succeed while still producing devastating complications. That is why informed patients approach surgery differently. They ask hard questions, they request second opinions, they explore alternatives, they optimize their health first whenever possible. None of this is anti-surgery. Surgery remains one of the greatest achievements in modern medicine. Joint replacements restore mobility, heart procedures save lives. Cancer surgeries eliminate dangerous disease. The issue is not whether surgery works. The issue is whether surgery is truly the right choice at the right time for the right patient. Many people over 50 grew up believing doctors should never be questioned, but modern medicine has become too complex for blind trust alone. Healthcare works best when patients become active participants instead of passive recipients. That means understanding your diagnosis, understanding alternatives, understanding realistic outcomes instead of idealized promises. It also means recognizing that every intervention carries trade-offs. Sometimes surgery dramatically improves quality of life. Sometimes conservative treatment accomplishes enough without exposing the body to unnecessary risk. And sometimes the bravest decision is slowing down long enough to gather more information before making a permanent choice. Fear pushes people toward rushed decisions. Information creates better ones. The goal is not to reject medical care. The goal is to approach it with clear eyes, thoughtful preparation, and a willingness to ask the questions that many patients are too intimidated to ask. Because once surgery happens, certain outcomes cannot be undone. That reality deserves respect, honesty, and careful consideration from both doctors and patients alike. When you step back and look at these 5 surgeries together, a larger pattern begins to emerge. First, hysterectomy for non-cancerous conditions is often recommended before less invasive alternatives are fully explored. Many women are never clearly informed that treatments like hormonal management, embolization, ablation, or pelvic floor therapy may successfully address symptoms while avoiding major surgery. Second, carotid artery surgery in asymptomatic patients reveals how modern imaging can sometimes push people toward procedures before evidence clearly supports intervention. For some patients, aggressive medical management may provide comparable protection without exposing them to immediate surgical risk. Third, robotic prostatectomy for low-grade prostate cancer demonstrates how fear can drive treatment decisions. Many men understandably want cancer removed immediately, yet long-term studies continue showing that active surveillance may provide equivalent survival outcomes for carefully selected patients while avoiding major quality-of-life complications. Fourth, multi-level spinal fusion reminds us that permanent surgery should rarely be the first answer for chronic degenerative back pain. Non-surgical rehabilitation, targeted therapy, injections, and structured conditioning programs frequently produce similar long-term improvements without permanently changing spinal anatomy. And finally, aggressive surgery in advanced dementia patients highlights one of the most painful realities families face. Extending life medically is not always the same thing as preserving comfort, dignity, or meaningful quality of life.